Tungufkali, anything.
Are we on?
All right, so we are live. I will, yeah, just a second, let me just.
It's from that.
Tu peux partager.
Maybe host.
So, for those of you joining online, we just want to say that we are now live on Facebook. So, you could kindly mute your microphone and just take care that you don't do other actions that that will be seen on Facebook. Yeah. So, and thank you all for coming. Yeah. Okay, so I'm good.
Stop recording. Stop recording. So can you just connect? I want to see what are you seeing on the screen? Are you seeing the shared screen?
Yes, sir.
Okay. All right. Thank you, Omar. I think we yeah. Presenter. Just minimize it.
So just
You should still be. Money.
And I'm putting on pink too. Okay, so
Sorry.
Okay, so I think just want to thank the Department of Study, like especially breast cancer awareness. Part of what we do is health advocacy. That is very, very, very important. We are after this, taking out only these things for cancer. October is the month of cancer. It's inspired by freedom. So when we talk about cancer, inspired by freedom, inspired by freedom, we are cancer variety. So that's what happens. Yes. So are those medical students? Medical students? Medical students? Which year? Which cohort is that? Anybody wants to do the production? Anybody wants to school the last time? Where your course? Yes, properly. Put on your course, put on your tie. So that's what we have. We have about it. So let's get it. Thanks to the surgical department and for yours. Thank you so much. So we are going to be live, sharing on the GAT page also, Facebook page, so we can just send it from here.
okay, good morning, head of department, deputy head of department, the consultants and residents, as well as medical students. First and foremost, I would like to thank you all for joining us in showing solidarity and awareness on breast cancer. Actually, this Pink October is actually dedicated for breast cancer awareness. As we all know, breast cancer is one of the top leading causes of cancer mortality in women, and especially in poor resource countries or poor resource setting. Unfortunately, women tend to present at an advanced stage in which may result in survival rates. In order to commemorate this Pink October, the Department of Surgery, in collaboration with the Department of Pathology and Laboratory Medicine, will be presenting a lecture series on breast cancer. And this is going to go on for the next 2 weeks on Wednesdays. The presenter for today's discussion is Dr. Jaiteh. This is for the benefit of the wider audience. Dr. Jaiteh is a consultant general surgeon with a keen interest in surgical oncology, especially those of breast cancer. I will be the moderator for today's exercise, and I would like to put down just a few rules. So please, I will urge all of you to, during the question and answer session, to make your questions short and precise. So without further ado, I would like Dr. Jaiteh to speak on the clinical approach on breast cancer. So Dr. Jaiteh, you can bamboozle us as much as you can. Thank you.
So for those who are joining us online, can we please mute our mics so that we can all hear the presentation? Like Dr. Lee mentioned, this is a series of lectures that are going to be based on breast cancer and breast cancer awareness. Since we all know October is Breast Cancer Awareness Month, commonly called Inktober. And as a department and as a unit, we saw it fit to help create awareness when it comes to breast cancer. I'm sure we all might have had some sort of encounter when it comes to breast cancer. We might have seen somebody who had breast cancer. We might have a friend or a family member who has had a journey through breast cancer. So it's not an uncommon condition. And as healthcare workers, it's important that we are aware so that we can create awareness in our communities and help alleviate the burden of this disease. So today's lecture is going to be the first lecture on a series of lectures. We hope we'll be having a lecture every week. So it's going to be spanning over 4 weeks. And we hope to touch on the different aspects of breast cancer. So the first lecture that I'm going to be doing today is going to be on the clinical approach of breast cancer. And hopefully subsequent lectures will also talk about the different particularities of breast cancer, including how we are managing breast cancer in this country. So as my title says, breast cancer clinical approach. As clinicians, we would be faced with patients who may have suspected breast cancer. How do we deal with these patients? So that's the topic of discussion in today's lecture. I'll start off by saying, or asking the question, what is cancer? This is a word we hear a lot, and it evokes emotion in us. And if you look at it, the scientific definition of cancer, in simple terms, would be an abnormal and an uncontrollable growth of cells. That's in very plain English. That's what cancer can be defined as. We all know that in our bodies, we have cells that are responsible for growth, and those cells have a certain lifespan. But in cancer, that lifespan is not respected. So you can have cancer affecting different parts of your body. And for breast cancer, it's cells that are uncontrollable and abnormal growth when it comes to cells of the breast. What causes it? This is the million-dollar question. Nobody knows what causes breast cancer. We do know what causes a few cancers, like cervical cancer. We know that most of it is caused by HPV infection. Liver cancer, we know that hepatitis B and C can cause liver cancer, but in breast cancer, we do not really have an idea what causes it. All we know that there is an abnormality in the DNA which gets damaged, and then cells become mutated, and then they go out of control. It's important to note that breast cancer is actually the leading cause of cancer in women, but in the Gambia, it's a bit different. Anybody know what the leading cause of cancer in the Gambia is? In women? Sorry? Did you get that? Breast cancer is the leading cause of cancer around the world. But in Gambia, it's not the leading cause. It's probably the second. What's the first? What's the first? It should be an easy question. What's the first? Madeline. Sorry? Yes. Cancer of the cervix is actually the leading cause of cancer in the Gambia. But breast cancer is not too far behind. So what happens? You have normal breast cells. Obviously, you have the normal anatomy. This is the breast. You have the lobules that lead to the ducts. The ducts, lobules produce milk. They're transported through the ducts, and then they come up to the nipple. You can have abnormalities in any of these sites. So when you have cancer of the duct, it's called ductal cancer or ductal carcinoma. Or when you have cancer of the lobules, it's called lobular carcinomas, cancers. So already here we can tell that cancer can affect different parts of the breast. So normally this is how your ductal cells should look like. They're well arranged, well organized. When you start having some level of abnormality and abnormal growth, you start having what's called hyperplasia. And then eventually that grows further and then it starts going beyond the cell membrane, and then you have what's called in situ carcinomas. And then eventually it becomes invasive when it goes beyond that cell. And then metastatic when it starts going into the bloodstream. So this is the natural evolution of cancer and cancer cells. The particularity of breast cancer is that this is a cancer that is fueled by hormones. And those hormones are mainly estrogen, progesterone, what's called the HER2 receptor that accepts certain signals. And these three hormones actually participate in the growth of cancer when it comes to breast cancer. And then we'll see this later on when we talk about treatments, because we know that breast cancer actually has sensitivity to these hormones. So it's like a fuel that helps the cancer cells grow. So we can use that when we're trying to treat these cancer cells in our therapeutic management. So why is it important? Why do we have a whole month for breast cancer? Why don't we have a month for other types of cancer? Like I mentioned at the beginning, it's the leading cause of cancer in women. There's a second leading cause in the Gambia. So if you look at this chart or this map, you can see the darker areas are where you have a higher incidence of breast cancer diagnosis. The lighter areas are where you have a lesser incidence of diagnosis or prevalence. And I say diagnosis because obviously you can see these are the industrialized countries. They may seem to have a higher prevalence rate of breast cancer, but that doesn't necessarily mean that the other countries don't have it. We're probably not diagnosing it, and we're not probably reporting it enough. I think you can make that down there, right? Not sure what color it is. It's actually leading cause, like I mentioned, of cancer deaths. So it's not just cancer in terms of the numbers, but also the leading cause of cancer death in women. So a statistic would be, for example, in America, 1 in 8 women would be diagnosed with breast cancer in their lifetime. That's not a small number. Breast cancer is the most common cancer, like I mentioned, worldwide. The map, there's a disparity, and we saw the different shades of blue. And the reason for that, when I mentioned incidence, it's the reporting. So you probably have a better reporting, and diagnosis is done better in the West compared to our part of the world. Lifestyle factors. You may actually have a higher incidence of breast cancer, maybe let's say in America, compared to Gambia. And the reason for that is partly due to lifestyle factors. The type of food we eat, the prevalence or the amount of obesity that's in America may not be in the Gambia. And we'll see some of the risk factors of breast cancer that would lead to high incidence in the Western Gambia. You can have genetics. Genetic mutations can also participate in development of breast cancer. Preventive measures, this is something that's very important. I think as much as we are able to diagnose breast cancer in Western countries, the amount of prevention that's taking place there allows for better survival and low mortality rates. So again, when we talk about mortality, we tend to have a higher mortality in our part of the world because we're not diagnosing it on time. And we do not necessarily have all the equipment or the facilities in order to be able to treat our patients. So that's also another disparity when it comes to the global north and south in terms of mortality rates. I spoke about risk factors. At the beginning of my presentation, I said that most cancers, we don't know what causes it, but we do have factors that can increase your risk of getting breast cancer. And we'll take a look at some of them. I'm sure we all at least have an idea of a few. In order to make this easier, we'll classify them into two. We'll have modifiable risk factors and you have non-modifiable risk factors. So modifiable risk factors are risk factors that you can actually do something about. And non-modifiable ones are the ones probably you're born with and you do not have any control over. So if I were to ask the question, if we were to reduce our risks, which of these factors do we think we can actually play on? Which of these factors, modifiable or non-modifiable, that we can actually influence? The ones at the back. Ready? Simple question. This is true or false. So we only have two options. Choose one. If we were to be able to have an impact, you have risk factors. Risk factors means things that can actually increase your risk of getting breast cancer. So which of these two factors do you think we can actually play on in order to be able to reduce somebody's chances of getting breast cancer? Very cool. Modifiable. So it's pretty straightforward. So non-modifiable ones are the ones you really can't do much about. Modifiable ones are the ones that you can actually have an impact on. And those are the ones we're going to focus on. So looking at the non-modifiable factors, you would have something like age. The older you grow, the higher your chances of getting breast cancer, although they are exceptions to that. Gender. Who do you think breast cancer affects more? Men, women, transsexuals. Which one? Women, of course, yes. So women tend to have a higher risk of getting breast cancer. Okay. Family history, we have somebody in the family who has had breast cancer, your chances of getting breast cancer are higher. It doesn't mean that you're going to get breast cancer, it just increases your risk of getting breast cancer. Genetic changes, so there's certain gene mutations that if somebody has a higher risk of getting breast cancer. We'll look at a few of those mutations. Menstrual cycle and menopause. So somebody who starts seeing their menstrual at an early age, menarche. Let's say if you have two people and one starts seeing their menstrual cycle at 9 years of age and somebody starts seeing it at 14. The one at 9 years of age probably will have a higher chance or higher risk of getting breast cancer. And the same is true when it comes to menopause. So menopause being, for example, somebody who continues seeing their periods till maybe at the age of 55 or maybe even 60 would have a higher risk of getting breast cancer compared to somebody who stops seeing their menses at 45. So what this means is it's the menstrual cycle of that individual. So the longer the menstrual cycle, the higher the chances of getting breast cancer. And the reason for that is because, as we mentioned, it's a hormone-based cancer. So it's a cancer that feeds on hormones. So the longer you're exposed to the hormones, the higher the risk. Breast density, so that's something also that actually increases your chance. It's actually been found that Black women tend to have denser breasts. So that also increases our chances of getting breast cancer. The race, like I mentioned, that also plays a part, probably genetics as well. So these are not modifiable risk factors. So there's nothing you can do about your age. You can't go back. Once you're 25, you're 25. You can't go back to 24. Your gender, you can't change. Although some people do try, but you can't change it. So that's not something that you can modify. So if you look at these non-modifiable risk factors, you realize that there are two most important ones, actually the age and the gender. Those are the most important when it comes to non-modifiable risk factors that increase your chances or risk of getting breast cancer. Okay. But it's important to know that men also do get breast cancer. It's not just women. Things that you can do something about. Modifiable risk factors. So number one being overweight. You can actually influence your weight. So you can reduce your weight. When you reduce your weight, you reduce your chances of getting breast cancer. And the reason why weight is important is because, again, it comes back to this hormone sensitivity we talked about. When somebody is a bit obese, it means that you have a little bit more fatty tissue, adipocytes. So estrogen can be produced from adipocytes. You have a conversion that takes place in the adrenal glands, and then eventually it can be transformed into estrogen. So controlling your weight can actually help reduce your risk of getting breast cancer. Physical inactivity goes with being overweight. Obviously, if you're physically active, you're less likely to be overweight. Alcohol consumption, that's something that exists. Thankfully, not as much in Gambia, but it still also increases the chances of breast cancer. Hormones, so for example, women who are on menopause and who are actually taking hormone replacement therapy have a higher risk of getting breast cancer. Things that protect you, in a way, pregnancy. But when a woman is pregnant, there's a sort of a break from that exposure to estrogen and hormones. So that actually acts as a protective mechanism. I think this is one of the things that our grandmothers would encourage young women to get married. I think if that wasn't convincing enough, I think this probably should be. So pregnancy actually protects against breast cancer. Breastfeeding, that's also another protective factor against breast cancer. Radiotherapy, on the other hand, actually increases the chances of developing cancer, including cancer of breast. So these are again modifiable risk factors. These are things that can actually have influence and an impact on when we're trying to reduce the risks. I mentioned something about genetic mutation. There are a lot of genes actually that can participate in breast cancer development. And you have genes like BRCA10, you have CTH1, TOX3. You have a variety of genes, and most of these genes are actually helpful in preventing the development of cancer. But when you have mutations in these genes, they actually increase your chances of getting breast cancer. So we have the very rare ones like BRCA1 and 2, which are quite rare, fortunately. But if you're fortunate to have these mutations, you stand a very high chance of developing breast cancer. Compared to TOX3, which is common, you can have a lot of people who have the TOX3 mutation, but they're unlikely to develop breast cancer. So the focus more is on these ones, although they're rare, but then they give a higher risk of developing breast cancer. So BRCA meaning breast cancer gene multiplies other gene mutations, very rare, but a high risk, like I mentioned. So somebody with a BRCA mutation has an 80% likelihood to develop breast cancer and a 50% likelihood of developing ovarian cancer. Looking at this chart, somebody who's in the normal population who doesn't have a gene mutation and somebody who has a BRCA mutation has a chance of developing breast cancer. That's 0.5% in the population. So, at the age of 70, that patient has a likelihood of developing almost 85%. So it's almost certain that they will get breast cancer. Males, the likelihood of any male getting breast cancer is less than 1%. But with a BRCA mutation in their family, it means that they have a 7% chance of getting breast cancer. Ovarian cancer, similarly. Prostate and pancreatic cancers also have BRCA mutations in them. So again, it's a rare mutation, but it's a mutation that increases your chances of getting breast cancer. We talked about the risk factors. Why is it important? Again, we don't know the causes of breast cancer, but we do know the things that increase the chances of breast cancer. But medicine is not an exact science. What it shows is that patients without known breast cancer make up about 60 to 70% of patients with breast cancer. Only about a third of patients with known risk factors actually have. In other words, somebody who is obese has a 67% chance of not having breast cancer. The risk factors don't mean that if you have this risk factor, you can get breast cancer. But it doesn't. So the message here is those who have risk factors, yes, they do need to be aware because they stand a higher chance. But risk factors doesn't mean that they're safe either. They also need to be careful. I mentioned something very important. I said that there are two main non-modifiable risk factors that are the most important. That is the age and the gender.
So, but Belis, it'll go near it.
Why do we screen for breast cancer?
Moment drop.
The rationale behind screening is because we don't know who has breast cancer. And if you don't know what's causing breast cancer, you can't necessarily prevent it. But what you can do is diagnose it in time
It for December.
and be able to manage it accordingly.
20.
The concept of screening comes
Belis,
with what causes it. So the screening has different phases. You have what's known as self-breast examination. You have clinical breast examinations. You have imaging in the form of ultrasound and mammography. Examination, 40% of breast cancers that are diagnosed are actually based on women who are able to palpate and feel a lump. So this breast self-examination
No, but then you work and then these people, I'm not going to be online with them again.
And then they would do it 5 to 7 days after the start of their menstrual cycle. And again, this is a habit that when outreach programs are done in order to sensitize patients for potential patients, they should be able to learn their normal potential, eventually be able to know when something abnormal happens. So again, so for those who are online, please, can we mute our mics so that everyone can hear? So again, on the breast self-examination, it's what's called the look and feel. So the female would palpate their breast most of the time in the shower. They would look in the mirror to see whether there are any differences, any asymmetry within both breasts, whether there are any skin changes, whether there's any puckering. They would also lie down and feel for any lumps. They would also see if there are any spontaneous or express discharges from the liver. So all these exercises are taught to women so that they can know their normal anatomy. And when something abnormal appears, they will be able to detect it. Concerning self-breast examination, there was a randomized controlled trial that was done in China and in Russia, which showed that those women who did self-breast examination had reduced patients seeking medical advice. They eventually were able to palpate something on their breast, so it led to increased rates of biopsy. Fortunately, most of those were benign lesions. They were not cancerous lesions. So there was no increase in the rate of diagnosis of cancer. So this result can be interpreted in different ways. Number one, if cancer were to be there, it would have been diagnosed early. But it can also be a source of anxiety for the women. So self-breast examinations, according to this clinical trial, may not be the most efficient way of actually diagnosing breast cancer. So second method of diagnosing or screening, screening for breast cancer. That's the clinical breast examination. So it's similar to the self-breast examination. The difference here being that it's done by a health professional, somebody who's trained on detecting the abnormalities of the breast. And this, most of the time, is a doctor. But in our local context, it doesn't necessarily have to be just a doctor. We do not have enough doctors. So you can have nurses who are trained in order to be able to detect abnormalities. So what you're looking for is bumps on the breast, under the armpit, or it can be physical changes of the breast. The goal, again, like I mentioned, is early detection. You cannot prevent breast cancer, but you can detect it early enough to be able to manage it. So for the clinical breast examination, there was another randomized control trial, this time in India. And then they realized from their trial that clinical breast examination was able to diagnose more cancers. Although the sensitivity was mediocre at 51, but their specificity was about 94, which is quite good, meaning that they were able to tell that it was actually cancer. So what that led to was better detection of early breast cancer, which allowed downstaging, meaning that instead of the woman being detected at a stage 3, maybe the lump that's 5 centimeters, they were being detected at maybe at 1 or 2 centimeters. So clinical examinations that are taught, for example, to community nurses would help in detecting breast cancer cases at an earlier stage with better prognosis. So you see patients at an earlier stage. The third method of screening after the self-breast examination, the clinical breast examination, is the screening mammography. So this is done in asymptomatic women aged 40 or younger. The reason being, in younger women, you tend to have denser breast. And once the breast is dense, mammography would not be able to detect certain changes because all you see is white and the lesion is white. So you cannot see white on white. So it's much more advisable for women 40 and above because they tend to have a little bit more fatty tissue than dense breast. So breast density affects the sensitivity, like I mentioned, in mammographies. The good thing about mammographies is that studies have been done and it has been realized that it actually reduces the mortality due to early detection in the age groups of 50 to 69. Those who were younger than this, they did not see the benefit of a mammography. This is the key point. But again, these are studies that were done in a different population, with different lifestyles, with different patient subsets. It doesn't necessarily mean that this would apply to our local context, and we'll see that a little bit further down. So factors to consider in screening mammography is the population and age distribution. Like I mentioned, we tend to have a younger population. Our life expectancy might not be as high as the West. So doing a mammography at 50, we may not be catching early enough most of our cases and patients. Cultural beliefs. Some people do not believe in breast cancer. So getting them to actually go for a screening mammography on a regular basis every 2 years or every year is going to be a tall order. Personnel and equipment. We need to have enough radiologists. We need to be able to do stereotaxic core biopsies because sometimes in a mammography, you wouldn't see a lesion or a lump. What you would see is called calcifications. So those may be ductal cell carcinoma in situ, but they might be the beginning of a cancer. So you need to be able to actually biopsy those regions, and that would need specialized material. Placement, geography, and access. If you to have a mammography, you have to make sure that you had one in Banjul, you had one in Bansan, one in Basit. So the logistics behind it is something that would be cost consuming, and you would have to consider that. Payment, screening, diagnosis, and treatment. So if you actually diagnose breast cancer, you need to strategize how you would actually treat that patient, because cancer treatment is not cheap, and it's something that obviously requires a lot of resource mobilization. So with this screening mammography, it has to be a holistic approach. It's not just detecting breast cancer and stopping at that. Pitfalls, you might overdiagnose. Sometimes on a mammography, it says, looks like breast cancer. You go and do further tests and you realize it's not breast cancer. So you might be overdiagnosing in a way. You can cause anxiety to the females, because they're thinking it's cancer, it's not cancer. So a lot of anxiety can be created, along with false positives and negatives, and also radiation exposure. It's like an X-ray. So you're actually being exposed to radiation. You mentioned that radiation is actually a risk factor of breast cancer, along with other cancers. So what's a recommendation? The WHO says women between 50 and 69 in resource-limited settings with weak health systems, when the majority of women with breast cancer are diagnosed at a late stage and mammography screening is not cost-effective and feasible, early diagnosis of breast cancer through universal access of women with symptomatic lesions to prompt and effective diagnosis and treatment should be high on the public health agenda. The key words here is early diagnosis. So that would go through clinical breast examination. Like I mentioned, for example, in our context here in the Gambia, we may not have enough doctors. So what can be done is to have community nurses who will eventually be able to examine women and help detect these cancers at an earlier stage and refer them. And also have low-cost screening methods. And mammography may not make a lot of economic sense in our setting. We have other methods like an ultrasound that can actually be used in order to be able to differentiate between benign and malignant lesions. This is the recommendation for resource-limited countries like ours. I mentioned ultrasound. Usually it's not part of your screening, but it can be an adjunct to mammography. The advantage is that there's no radiation. However, it's user dependent, so there is some training involved. Somebody who's well trained can actually help diagnose a lesion that's suspicious, and somebody who doesn't have enough training needs this lesion. It's also good for dense breasts because we mentioned that dense breasts don't do well when it comes to mammographies. And also it can help distinguish between cystic and solid lesions. You would also use an ultrasound as an adjunct to clinical breast examinations. So, for example, if you're in the community and you have a nurse who's trained in detecting breast lesions, they can also have, instead of a mammogram, they can actually have access to an ultrasound and be able to make their diagnosis. This is mostly where mammography isn't readily available. So the breast cancer global initiative guidelines for detection says that where you have basic resources, you would be the best approach to have breast health awareness, so that education and self-examination, and clinical breast examination where possible, and then you do your baseline assessment, that is an ultrasound. Where you have limited resources, you can have targeted outreach and education encouraging clinical breast examination for high-risk patients. This would enable you to be able to downstage symptomatic disease. Again, instead of them coming with lumps that are 5-6 centimeters, they'll be coming with lumps with 1 or 2 centimeters. Where you have enhanced resources, then you can talk about diagnostic mammography or opportunistic mammography screening. And what that means is, when a patient comes in for another health condition, you can take that opportunity to do mammography in order to be able to screen them for breast cancer. And where you have all the facilities at your disposal, and you have a population-based mammography, wherein everybody who's 50 and above has a mammography every year or every 2 years. That's the ideal setting. I guess we all know that we're very proud of this. I think we're probably at basic and most limited. And this also varies. Maybe in Bangalore we're limited, and maybe in Bangalore we're at basic. But again, these are guidelines that are actually adapted to different levels of resources. So that was on screening of breast cancer. We look at diagnosis, and the difference here is you screen for asymptomatic patients, somebody who does not have any signs and symptoms, and you're trying to see whether they may have asymptomatic breast cancer. Diagnosis concerns patients who actually have signs and symptoms. How do you actually manage these patients? Breast cancer symptoms can vary. You can have anything from nipple discharges, skin changes, dimpling. It can be a change in skin texture. You can have pulling in or inversion of the nipple. You can have a lump that's visible, that's also palpable. You can have lumps within the armpit. You can have signs of erythema or reddening or irritation of the skin. And you can also have visible lumps as well. So this list is not exhaustive. You can have a host of signs, a host of symptoms rather, that the potential patient will be complaining of when they present to the clinic. Again, you can have skin dimpling, you can have puckering, you can have swelling or erythema, inflammation. You can also have asymmetry within the breast. You can have itching or scaling, or you can have pain. But I'll be quick to add that breast cancer is not painful, especially at the beginning. Most breast lumps, almost 80%, would not be painful. And that actually leads to the delay in diagnosis because most people come to the hospital when they feel pain. They may have a lump, it's painless, and they will stay at home. Once they start seeing it grow to bigger proportions or it starts paining, that's when they present. It's important to note that breast cancer at the early stages, most often than not, is not a painful lump. So how do you diagnose? There's what we call a triple assessment. That's the clinical breast examination by a health professional. Imaging studies, so that's either ultrasound or mammography, or even sometimes an MRI. And then you have histopathology studies. So studies that involve taking tissue samples. Once you're able to make your diagnosis through your triple assessment, you also want to stage your disease. What staging means is basically trying to find out at what level the cancer is. Is it a cancer that's localized within the breast? Is it a cancer that's locally advanced? It's the breast and maybe the chest. Or is it a cancer that's more metastatic? So it's a cancer that has left the breast tissues and has gone to other parts of the body. So that staging can be done either clinically. So for example, you can have a patient with breast cancer and you do a clinical examination. You do an abdominal examination and you're able to palpate maybe hepatomegaly, or you're able to palpate nodules. So that most likely might be metastatic breast cancer. You also look at the armpits. So breast cancer that's left the breast and has gone onto the armpit to be able to palpate that. But the most reliable way of staging would actually be imaging. So that would include things like a CT scan, things like a PET scan. That would be able to actually find out whether the breast cancer is localized or advanced. Because your treatment also is based on the stage of the disease. So we have an ultrasound, apart from your mammography. So your mammography can be for screening purposes, but it can also be for diagnostic purposes. In high-risk patients, people who have a family history, for example, of a BRCA mutation, you would go further in doing what's called an MRI. So that's a magnetic resonance imaging that would allow you to be able to detect any suspicious lesions in these patients. They tend to be younger patients. Histopathology. This is going to be a subject of a whole lecture next week, Wednesday. But I will just touch on it briefly and say that histopathology studies are almost always necessary for you to be able to make diagnosis. Something can look like breast cancer when you examine it clinically. It can also look like breast cancer when you look at the ultrasound and the mammogram. But the only way you can confirm that this is actually breast cancer is through histopathology. So this is a very, very key component, and that's where Dr. Lee and Dr. Owen come into play. So how do we actually get these samples? You can do a fine needle aspiration cytology. So it's a small needle that you use, and you aspirate the cells from the lesion. You can do a full needle biopsy. So this is a biopsy that's, the needle that's a bit bigger. It's it has a larger opening. So it allows you to take not just the cells, but also part of the surrounding tissue. And this allows for better reading when it comes to suspicious lesions. In some cases, we go ahead, if it's a small lump, instead of doing 4 needles, we can just go ahead and remove the whole lump and maybe a little bit of surrounding tissue around it, and then send it for histopathological studies, again, to be able to confirm whether it's benign or malignant. Most of the time, they respond from the lab, they'll tell us if it's malignant or benign, they'll tell us the grade. Is it well differentiated, poorly differentiated, moderately differentiated? All these have a prognostic factor to it. Also, receptors. We mentioned at the beginning, this is a cancer that is hormone sensitive. So it's a cancer that feeds on hormones. So it's important to know whether that cancer is actually sensitive to hormones or not. So the staging, anatomically, we've all heard of the TNM. So that's a tumor, side of the tumor. Note whether there are any lymph nodes under the armpit or at the supraclavicular region, and can be metastasis, meaning that whether the tumor has actually spread beyond the breast and the surrounding tissue to further areas of the body. The staging also, nowadays, you have the histopathology studies that contribute to the staging as well. So the grade, like I mentioned, a poorly differentiated cancer has a worse prognosis than a well-differentiated cancer. Okay. Hormone status, cancers with hormone receptors that are positive give you more options when it comes to treatment than cancers that do not have hormone receptors. And HER2, so that's a human epidermal growth factor receptor 2. The status as well allows us to be able to use certain medications or molecules that can actually help when it comes to fighting breast cancer. More recently, there's what's called genomic testing. So things like oncotype scores, they help to determine the risk of recurrence in patients with breast cancer, and also help to tell whether hormone receptors would be useful or not useful in certain patients. So this is an example of the American Joint Committee on Cancer classification of breast cancer or staging. So T1, for example, would be a cancer that is less than 2 centimeters. T2 would be between 2 and 5 centimeters. T3 would be more than 5 centimeters. The T4 would be any size with involvement of either the chest wall or the skin or both, or what's called an inflammatory breast cancer. That is inflammation or erythema around the whole breast because of the cancer. So again, this is the T stage. You have the lymph nodes as well and the metastasis. And this would allow us to be able to stage our cancers into stage 1, 2, 3, and 4. The interesting thing I would like to mention is that when we talk about breast cancer, the impression we have is it's one disease. But recent studies have shown that breast cancer is not one, multiple. And as a result, the treatment cannot be the same. You can have 2 patients who have breast cancer, but their treatments would be separate, would be different at some point. And it's important to note these differences. The differences would be, for example, in histological subsets. So you can have either pre-invasive, meaning a cancer that's limited within the cells, or it can be an invasive cancer that's a cancer that's gone beyond the basement membrane. So those are cancers, for example, it's the duct, like we mentioned, it could be a ductal carcinoma in situ. If it's the lobules, there would be a lobular carcinoma in situ. The consider difference, the management differs. If it's an invasive cancer, you have an invasive ductal carcinoma, which is actually the most common. If it concerns the lobules, then you have an invasive lobular carcinoma as well. The risk of metastasis is also higher. There's also the molecular subtype, and this is quite recent, and I believe maybe the lecture next week would touch a little bit on it. But the reason why I'm talking about it here is just to show you that within the breast cancer umbrella, there are different subtypes. So you have the luminal A, the luminal B, the HER2 positive, and the basal type or triple negative. And you can see that the luminal A is the most common type. The luminal type actually makes 60%, luminal A and B. And then the other 2 make up about 40%. So the luminal A is the breast cancer type, which has receptors, hormone receptors that are actually positive. And we'll see why that's important. The luminal B would be where you have less likelihood of having positive hormone receptors. But then your HER2 receptors tend to be positive with it. So the luminal A and B tend to be low grade, and the HER2 tends to be a higher grade. Prognosis obviously goes with the luminal A and B. And your choices when it comes to therapeutics, since these are oestrogen positive cancers, they tend to respond more to hormone therapy. We'll look at hormone therapy when we look at management. So they tend to respond more to hormone therapy. The HER2s tend to respond more to what's called targeted therapy. And then the triple negatives are treated primarily through chemotherapy. So there's no need to give a triple negative, because what they mean by triple negative is actually estrogen negative, progesterone receptor negative, and HER2 negative. So they're treated differently. So again, these molecular subtypes tells us that there is not one type of cancer, but then there are multiple subsets of breast cancer. Again, the staging here is to show us that stage 0, cancer is in situ, it's within the cells, so it's a cancer that's easily manageable and treatable. Stage 1 would be early breast cancer. The cancer is limited to a small region. Stage 2 will be localized, so tumor, for example, between 2 to 5 centimeters, like I mentioned, and you may or may not have lymph nodes that are involved. Stage 3 is when you have lymph node involvement, and stage 4 is when you have distant metastasis that go beyond the breast tissue and then into other parts of the body. The common areas of metastasis would be the brain, the bones, the lungs, and the liver when it comes to breast cancer. What are the guidelines? So again, the Breast Health Global Initiative diagnosis guideline says, for those who have basic resources, how do you go about diagnosing breast cancer? You take a proper history of the individual, a family history. Is anybody in the family who had breast cancer? You want to do a physical examination, clinical breast examination, eventually a surgical biopsy, and then you have an interpretation of that biopsy. That's in a very basic setting. With limited resources, you want to do a whole needle biopsy along with the history, physical examination, and clinical examination. And if possible, determine the receptor status, whether it's estrogen positive or progesterone positive, and that will also help determine the treatment guidelines. Obviously, you would have access to ultrasound and maybe a diagnostic along with it. You also want to do plain chest X-ray. You want to do an ultrasound. Again, these are staging methods in order to see at what stage the cancer is. Moving on to the aspect of treatment. Again, this distinction is very, very important. It's important to know what you're dealing with. Is it an early stage breast cancer or is it an advanced stage breast cancer? Because your management will differ. It's a multidisciplinary approach. So it's not one person treating breast cancer in their corner. You need to have the participation of several members. So you need a surgeon, either a general surgeon or a surgical oncologist. You would need to have a medical oncologist, somebody who will be giving chemotherapy if it's available. You need to have a radiologist to be able to interpret your images adequately. You need to have a pathologist who will be able to actually look at your samples, be able to tell you whether it's cancer or not, whether it's hormone receptor positive or not. So it's not an individualized care. Unfortunately, in our situation, it tends to be that way. But in an ideal setting, it has to be a multidisciplinary team approach when it comes to management of breast cancer. What are our treatment options? Surgery, obviously. The reason why we are hosting this lecture. Hormone therapy. We mentioned that this is a cancer that is very sensitive to hormones. Radiation therapy. Radiation is something that can actually help kill or destroy cancerous cells. Chemotherapy. That's a drug that can actually be used in targeted therapy. Things like HER2. These are basically treatment arsenals when it comes to treatment of breast cancer. Surgical treatment. There are two main things we need to consider. Whether you're going to do what's called a breast conserving surgery or it's going to be a mastectomy. Obviously, the tendency would be to go in for a mastectomy. Which is another one. What would the likely option be? Is breast conserving surgery wherever is possible. It's not age dependent. Tendency is you always want to preserve the breasts as much as possible. Right? So mastectomy. For breast, but also the lymph nodes. With cancer, it's always good to know the state of the lymph nodes and whether they're affected or not, and whether they need to be removed or not. So surgery would be or mastectomy. Mastectomy can go with a reconstruction or without a reconstruction, depending on the preference. Lymph node evaluation, we want to see if those are affected. If we have an idea that the lymph nodes are actually affected, then we will go ahead and remove them in what is known as an axillary dissection. So this is a oral slide where the person recognizes absolute contraindication or breast conserving surgery would be if the patient doesn't want to have breast conserving surgery. No possibilities of radiation therapy, so you have to go ahead and remove the breast, because one condition with breast conserving surgery is that you don't stop at surgery alone. You need to be able to do radiotherapy. So, for example, in settings where you do not have any radiation therapy, your options of breast conserving surgery are very limited. But there's no possibility to do a mammography. It's a contraindication for breast conserving surgery, because with a mammography, you'll be able to tell if there are other lesions. And we're seeing more and more of that now. When a patient comes in and they tell you they have a lump on one breast, and then you do an ultrasound and you confirm that the lump is there, we often tend to limit ourselves to that. But most often than not, they may have multiple lumps, or they might have lumps on the other side. So mammography is quite important in order to detect that difference. When there's no possibility of having follow-up, it's better to do mastectomy rather than breast conserving surgery. When you have multicentric tumors, it's also important to actually do a mastectomy, because what multicentric means is that you have more than one tumor. So you have multiple tumors in that particular breast. When you have extensive microcalcifications, it's also an indication. But Jaiteh disease, it's a disease that's involved in the skin of the breast. So in which situation we would have to do a mastectomy. The others as well, if you have inadequate relation between the breast and the tumor, or if you have inflammatory breast cancer, that is an indication. Okay, in terms of relative contraindications, breast conserving surgery is also in relation to the tumor. You have somebody who probably has not enough breast mass and the tumor is large, you may not have much left when you remove the tumor. So a mastectomy would be indicated. Multifocal, so those are lesions that are within the same, multiple lesions within the same quadrant. So that would also be an indication of mastectomy. Somebody who's pregnant, for example, would have, if the surgery is to be done, ideally, it would have to be a mastectomy because, like I mentioned, breast conserving surgery goes with radiation. And somebody who's pregnant cannot receive radiation. So in order to prevent that eventuality, they would have to have a mastectomy. Others would include the advanced stage if they don't really want it. It's a gradual complication. Bulky breast that can allow for good recovery of surgical centers. But subsequent radiation therapy can be difficult because of the large breast size. Moving on to chemotherapy. So these are drugs that actually target all cells, not just cancer cells, but they target all the cells of the body. So they would destroy cancer cells, but then also destroy healthy cells. But the advantage with healthy cells is that they can recover faster than cancerous cells. So chemotherapy is used in fighting cancer, but the downside is that it has a lot of side effects. So chemotherapy has undergone a lot of evolution. So currently we have 3 generations. So the first generation of chemotherapy gave a benefit of about 35% in breast cancer mortality compared to those who did not have any chemotherapy at all. So agents like CMF, that's something that we use a lot here in Bantu. AC, so that's doxorubicin and cyclophosphamide, also 4 cycles, is also part of the first generation. The second generation, we have the addition of the taxides, so that's paclitaxel. That's also used in the second generation of chemotherapy. So compared to the first generation, you had a 20% reduction in breast cancer mortalities. And then the third generation has a combination of drugs, but also the techniques. You have things like dose dense, docetaxel, dose dense, doxorubicin, and cyclophosphamide combined with a taxane, that's a paclitaxel, gave about a 20% reduction in breast cancer mortalities compared to the second generation regimens. So you're getting better and better results from chemotherapy drugs that are being used currently. So the discussion is that there's no difference in survival whether you do surgery first and then you do chemotherapy, or you do chemotherapy and then you do surgery. But then there is a lot of tendency, the trend now is to do neoadjuvant chemotherapy before you start your surgery. For the following reasons. Once you give chemotherapy to somebody who has breast cancer, it allows you to be able to measure how effective that chemotherapy is. And in other words, it's the sensitivity of that tumor. So a tumor in somebody who's given chemotherapy before the surgery, and then they go in surgically and then remove that site where the tumor was. And then it tells you that they have a pathological complete response. It means that that tumor has disappeared with the chemotherapy. So that's a very good prognosis. In essence, it means that there's a higher likelihood of what's called a disease-free survival. So meaning that patients would be able to move on longer without having recurrence of the disease. It also improves on their overall survival as well. Another advantage of giving chemotherapy before surgery, it helps to downstage your tumor in your lymph nodes. So for example, if you're hoping to do a mastectomy because of the size of the tumor, it's 5 centimeters, and you give chemotherapy, it goes down to 2 centimeters, then you can consider doing breast conserving surgery instead of doing a mastectomy with that patient. And also lymph nodes can also be fed through that chemotherapy. So it increases your rate of breast conserving surgery, like I mentioned. So the tendency, again, whenever it's possible, is to give chemotherapy before you do the surgery, and then eventually move on to the surgery. But the option, sometimes you don't have any option but to do the surgery first. For example, somebody who comes in for toilet mastectomy, meaning that a cancer that is so evolved and it's infected, you have to do the surgery first and then eventually think about doing chemotherapy in an adjuvant setting, meaning after the surgery. Hormone therapy, the theme of this lecture is hormone dependent. It's fueled by hormones. So estrogen and progesterone receptors want to have something that would prevent them from binding to their receptors and sort of fueling that cancer. So you have anti-estrogen therapy, so tamoxifen, the most widely studied hormone receptor, and progesterone. Those are the 2 receptors that are most widely studied. They bind to their receptors and then they block the uptake of estrogen by the breast tissue. So if there's no estrogen or hormones, then the breast tissue or the breast cancer ceases to grow. And in patients like this, you can remember the type of patients we said who are hormone receptor positive, the luminal A, B, basal type, or negative. You remember the molecular subtype we said you had hormone receptors that were positive between luminal A, B, basal type, and negative. The hormone receptor, the estrogen receptor. Does anybody remember what subcategory of patients did we say had a higher likelihood of having estrogen receptors that are positive? Idea? Anybody? Yes, please. Yes, so we said the luminal type A and B. And the reason why that sub classification was given, it helps you tell the different types of breast cancer, because breast cancer is not managed the same way based on the subtypes. So the luminal A and B would be the types that we most likely need tamoxifen. Okay? And tamoxifen is an anti-estrogen. It prevents the binding of estrogen to the receptors on the breast cancer cells, and that helps to slow down the growth of the cancer cells. So it's mostly given in the adjuvant setting, meaning it's after the surgery, and it's taken for about 5 years. It helps to reduce breast cancer mortality by a third through the first 15 years of follow-up, which is a very significant number. You can also have aromatase inhibitors, so they're more or less the same, but then they're used in postmenopausal women because you realize estrogen is produced by the ovaries, but after menopause, what happens? No more estrogen. Yes, there'll still be some. Remember we said obesity and that adipocytes can be converted into estrogen. So you actually have aromatase enzymes that help to convert those fatty tissues into estrogen. So in the case of postmenopausal women, it's not the, you can use some oxygen, but aromatase inhibitors are much more effective because they actually prevent the conversion of fatty tissues into estrogen. So molecules like letrozole and anostrozole are actually used in inhibiting the impact of estrogen on cancer cells. This is targeted therapy. We talked about the HER2. So you also have molecules that are tested. So you have anti-HER2 therapy. Bevacizumab is something that's used commonly. It's given for patients who have a HER2 positive type of breast cancer. This is also therapeutic that's used in that hospital. Radiation therapy. So this is just giving radiations in order to be able to kill the cancer cells. So you target the chest wall or the breast area, whether it's a breast conserving surgery that we did, and then you want to make sure that there are no residual tumors in the breast area. So you can do radiation therapy and target it mostly on that breast tissue in order to have maximum impact, but also minimizing the amount of side effects on the other surrounding tissues. What does the guideline say in terms of treatment? Stage 1, you will, in basic settings, meaning you don't have any radiotherapy. So what do? You can do a breast conserving surgery, because breast conserving surgery means you have to do radiotherapy afterwards. But in a basic setting where you don't have radiotherapy, your probably only option would be to do a modified radical mastectomy, and then eventually put the patient on tamoxifen if they have hormone receptor positive enzymes. In a limited setting where you may or may not have radiotherapy, if you do have radiotherapy, you want to do breast conserving therapy, and then you do irradiation afterwards, and then chemotherapy. First generation, you do the classical CMF, or you do a polymastectomy, then irradiation, and then chemotherapy afterwards. With enhanced settings, you have more options. Taxanes are very expensive. You can also give that as well. Stage 2, similarly, but then it's a higher stage cancer, so you want to give chemotherapy early enough, and then if they're hormone receptor positive, you also want to give that as well. breast conserving surgery in limited settings where there's radiotherapy, and then enhance, you have higher generation of chemotherapy drugs. In advanced settings, you want to do a modified mastectomy. You want to give neoadjuvant chemotherapy if you can, and then tamoxifen if you have hormone receptor positive as well. Stage 4 cancers, stage 4 meaning it's metastatic, so meaning that it's not just about where the cancer is on the breast, but then the cancer moves beyond that. And then you may consider surgery for palliative reasons. If it's an infected tumor or cancer, you want to do surgery to remove it. You do immunotherapy. If it's metastatic to the abdomen, you do things like hypothermic intraperitoneal chemotherapy, targeted therapy, and palliation. The patient is in pain, you give metastasis to the bone, you give them pain medication, you give them morphine. They're vomiting, you give them antiemetic drugs. So basically, you're trying to palliate and alleviate the symptoms that they may be facing due to the next stage. There's an interesting subset of patients, so Black women and breast cancer, that affects us in Africa and even Blacks in other countries. So Black women tend to get breast cancer at a younger age than white women. 23% of breast cancers in Black women are diagnosed before the age of 50. So meaning that the data set that says that breast cancer is patients 50 and above, that's why the screening is done at that age, is not necessarily true in our context. We're seeing younger and younger patients having breast cancer. 8% of Black women are diagnosed with metastatic breast cancer, compared to 5 to 6% of women from other races. So this underscores the importance of starting routine breast screening. If we want to screen, or start screening routinely in the Gambia, we need to reconsider the age at which we do it. Probably we'll get a little bit more data on what the average age is of diagnosis in third presentation. Breast cancer and gender. We talked about women, but men can also get breast cancer. About 1% chance of getting breast cancer, but it's still something. Prognosis, percentage of patients who are surviving, the number of years they're surviving. Somebody who's at stage 0, meaning carcinoma in situ. At 10 years, you have almost 95% of patients who are still around at 10 years of age. Stage 1, small, negative lymph nodes. At 10 years, you have about 86, 87%. But as you go further down the stages, then the 5-year survival decreases, as well as the 10-year survival. But the message in this chart is that once you're able to diagnose the cancer at an early stage, you're able to treat it at an early stage. The chances of survival are almost the same as a normal individual. So breast cancer reduction strategies, having a balanced diet is important. Having a healthy weight, we said obesity and having a sedentary lifestyle increases your chances. Being active, not smoking, avoid or reduce alcohol intake, and encouraging breastfeeding. All these are modifiable risk factors that can actually reduce our risks of having breast cancer. Conclusion, geographical isolation and policy, they lead to delayed presentation. So we need to get out there to our communities and talk to patients about breast cancer, talk to women about breast cancer. Make sure that we have breast cancer education. Community nurses need to be taught how to do clinical breast examination. They eventually help in early detection of breast cancer. The barriers we may be facing is social, psycho, and cultural beliefs. When somebody has a lump on their breast, what do they normally say? Especially if they're breastfeeding. Should I ask John? Any idea? Women breastfeeding. You've never heard that in the clinic, they never told you anything. Should I ask the other person from Monday? Let's come on. Nobody has ever heard anything at the clinics. A woman comes to you and she has a lump and she's breastfeeding, and they don't give their own explanation for the lump. They don't say what caused the lump. It's common. What do they say? Yes. So they'll say that the child belched on the breast. So that's a common belief. They feel that that has to do with breastfeeding. So our cultural beliefs and our psychosocial beliefs, it sort of delays presentation in the hospital. So again, there's a lot of sensitization that has to go on. Women need to be taught that anything abnormal on their breast needs to be investigated at the health facility. And once we're able to do that, then we eventually will be able to diagnose on time when it comes to breast disease. So 3 methods of early detection: breast self-examination plus clinical breast examination can lead to downstaging. Again, you cannot prevent breast cancer because we don't know the causes, but you can detect it early enough. And by having these examinations, you can actually help to downstage, meaning that diagnose it at an earlier stage. Mammography, where it's available, allows the detection of breast cancer at the early stages when cure is possible. When I say cure here, obviously it needs to lab difference. Early detection saves lives. Any questions?
Thank you for that presentation. It's a detailed presentation. If it is because of my fault, remember at the beginning of the lecture, I told you that us as much as he did. Indeed, he had spoken about the in terms of clinical evolution, as well as the different treatment modalities of breast cancer. But I just want to make comments. Sometimes I just want to question. This in terms of the non-modifiable risk factors. That's the age. That age is important in terms of breast cancer. It also makes, well, there's a common belief that goes that but in the Gambia, what we have seen, so what we are actually seeing the Department of Pathology relating to surgical biopsies of the breast, we are seeing indeed breast cancer in pretty young people. In fact, the peak incidence of breast cancer is within the 30s to 40s. Even in the 20s, I've seen a case, I think 2 years ago, a case of breast cancer, which was an invasive cancer, invasive ductal carcinoma, so to speak, in a 20-year-old. So these are very important. Well, time is against us. We will open the floor and entertain for now 5 questions or contribution. So if you have any question, kindly ask for any contribution. Please keep it precise and short. Thank you. Yes, Dr. Simon.
I'm sorry.
Okay.
Greetings.
Yeah. Yeah. Okay. 20. Yeah. Yes, that is a very important question. And indeed, there are prospects in looking at the molecular genomics on breast cancer in the Gambia. It's a study that we are planning to embark on in partnership with the MRC, with Dr. Abdul Karim Sise, who is the head of genomics in the MRC. So for this individual patient in particular, the breast receptor hormonal diagnosis was made in, I think it was in Ghana. We eventually sent the bloods. But for this individual patient, we've not made an attempt. We'll try and trace the individual. We've not made an attempt in order to look at the molecular sort of genomics as well as the receptors, because it is very possible that the siblings and close relatives will have BRCA mutation, which could warrant genetic counseling for other relatives to be detected, hopefully. But anyway, your question is a good insight. Yes. Okay. Okay. Of course. Yes. 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 And what I understood about such cases, I think the surgeons will elaborate on that. I think basically they offer, it's a mastectomy, prophylactic mastectomy. Yeah. So I think Dr. Jaiteh can elaborate on that.
I think the question you talked about you may have to take over one tendency now to be focused on trying to see how best you can. Sometimes you have to take that first step, which have a lot of side effects where they probably might have. And where breast cancer has a single disease, secondly, content, secondly, same molecules, and I think the question is quite likely to
yes.
hopefully with the assistance of the body, would be able to tell us what type of breast cancer. Not an example, but the patient is the cancer managed.
Any other question? Yeah, okay. Okay.
Yes, I didn't mention it, but probably with like when you have a BRC type 1 or 2, the chances of having breast cancer is about 80%. At age 40, somebody with a BRCA mutation so in cases like that mutation, you would consider prophylactic cancer and almost certainly. I think the biggest example would be who had that mutation. And she actually did two things. She did bilateral prophylactic mastectomy. So the chance of having breast cancer, and she went further to do Because the BRCA 1 or 2 mutation is supposed to be not just breast cancer, but also ovarian cancer. That would be 10%. So, interpretation is having first situation. But at least you know that you know that it's from under.
Okay. Yes.
Any questions? Yeah, contribution. We can announce it anyway. I think maybe they know everything.
Okay,
So,
any more questions, Dr. Mane?
I think that's a very important contribution, and I must admit, in preparing this slide, the decision was always what to keep and what to remove, so that at least the messaging is not drowned. But I think, yes, mammography is quite important. It's actually one of the main elements when it comes to screening. Again, in the settings where they actually did those studies. And I think it's something that we are doing more and more here in the Gambia. And it would be important to know what the grades are. So you're talking about things like the BIRATS classification, meaning from 0 to 6, 0 being nothing, I mean, no suspicion at all, or an incomplete test, till 6, where you have a biopsy that's actually confirming that it is. So I think that's an important addition, and probably we'll add it onto it before distribution.
Dr. Mane, that one also applies to the
Okay.
fine needle aspiration biopsy. Actually, it's should be categorized into 5 groups, just like the BIRAC. So like the group 1, it means the tissue obtained is insufficient for diagnosis, because fine needle aspiration is also operator dependent. So group 5, in the 2 extreme ends of the spectrum, 1 is insufficient, 5 is malignant. Then 2 is benign, and group 3 is essentially atypical proliferative lesion, and group 4 is the class that clinicians don't like at all when you say suspicious for malignancy. So I know that it could be difficult, but we are trying to make sure that whatever reports we give, the diagnosis should be unequivocally be clear. Yeah, because there are times when you look at the cells cytologically and the features of them may not have, I mean, all those malignant features, okay, to make a clear-cut diagnosis of malignancy. So it should be categorized into 5 main groups. Okay. So those who are online, please, if you have any question, can you kindly ask or give any contribution?
Professor, would you like to go first? Greetings.
Yes. Please go ahead. Okay.
Oh, I'm here. I'm here. Greetings. I was going to give way to Professor Fowler, but I don't know if she wants to contribute first.
Okay.
Okay,
Thank you very much.
you're welcome.
I am here. Thank you for that honor. But my contribution will be to this. I was looking at what Dr. Jaiteh talked about, the barriers to management, I think in the second to the last concluding slide. I think there's a place for the spiritual factor in this patients, in our patients. It's not just a question of the patient talking about psychosocial things or poverty. There is also, at least in my country where I come from, a lot of patients that you will see early, and you will do a fine needle aspiration biopsy, and you will tell them that there is a cancer there somewhere, and that, oh, come forward for a mastectomy. Mostly, they will not agree, and they will turn spiritual and say, I reject it, God will not let me have it. And they will go away and go and do every other thing apart from seeking medical treatment. So I think we should emphasize that too, about the place of spirituality, and people saying that they have prayed and that by their prayers they have been healed. Yes, I agree, there are miracles, but these things are real, and it does hinder the palliative care experts from trying to get forward to moving, and even the surgeons in particular to move on with the kind of treatment that you want. Thank you very much.
Thank you, Prof, for that. And I would want to agree with you. I think there are a lot of social factors that come into play. And like you mentioned, spirituality is also another one. I think perhaps in our effort for sensitization, we can have our faith leaders, that's our imams and our pastors, actually help bring out the message. In Africa, we're very glued to our Qurans and our Bibles and feel that everything can be solved through that. But I think also we need to reconcile with reality and know that not everything is just prayers. We also need to make an effort to take care of our own health.
Yeah, thank you. Greetings, everybody. My name is Sister Angie, and I'm actually tuning in from the UK. I was invited to this Zoom by one of our team members in the Gambia. So I want to ask one question and then make a comment after. What is the current survival rate in the Gambia for breast cancer?
The current, sorry?
Survival rate.
Current survival rate, on the top of my head.
Sorry, can you go on mute? Can anybody not, can you mute your phone, please?
Mike. No.
There's a
Your
very
mic.
bad feedback. Can you put your phone on mute, please, if you're not speaking? Thank you.
Just about the top of my head.
Sorry, there's a lot of interference. Mohammed Toure, could you put your phone on mute, please? Thank you so much. I really appreciate that. Sorry, Mr. Jaiteh, please,
Yes.
you can continue. I can hear you now.
Yeah, so to answer your question, we do not have any national studies that looked at breast cancer as a whole in the country. What we do have are center-based studies. So for example, we would do a study at the Edward Francis Small Teaching Hospital looking at our patient population that we receive here, and other hospitals would do the same. So the data may not necessarily be representative of the whole country. But again, like I mentioned, just at the top of my head, what we had in terms of survival was we have what you call a 5-year survival rate. So looking at how many patients survive after 5 years based on the staging. So from the study we carried out, we had about an 85% for those who were considered stage 1 and 2, and about a 69% of survival at 5 years for those who were considered a stage 3. It sounds a bit technical, but in other words, what that means is most of our patients who are seen at a relatively later stage than you would have in the West. and the rates comparatively are not as good. We are going to have a presentation in the next 2 weeks on the data concerning Gambia, or at least Edward Francis will be able to get. And perhaps there we'll be able to present a clear picture of what the survival rates are, the population, the age of our patients, and the type of treatment that they're getting.
Thank you. I'm very grateful for that information. And in terms of, I work in the NHS in the UK. I'll make that note. And as I'm going to say is that I also I've been visiting Gambia for many years from 2003. And I'm an alternative person. I practice an alternative way of living in terms of I'm a vegetarian. I live off the plant, you know, green and brown things. I don't eat meat or fish. In the Gambia, one of the things I notice is lacking. And I think I'm really glad for this presentation because I think information is key. But I think we also need to look at the prevention approach. So, you know, diet is a big thing. You know, from what I've gathered in the Gambia, you know, the quality of life obviously impacts on you know, health, but I think there need to be more focus on prevention. And I know you touched on that in your presentation. So thank you. What I'm going to say is we are an organization called Altogether Giving Africa, and we are a charity foundation that has been functioning in the Gambia for many years. And health is one of our main priority alongside education. They work hand in hand. We are holding a Health Awareness Day, and we have been doing this since 2017 in the Gambia. And I don't know if you know of Cherno Jaiteh. He's one of our team members from the Old Joshua Health Center. That's where we'll be holding the Health Awareness Day. This will be our 5th one. We haven't been able to hold them physically for the last 2 years due to the current situation with the pandemic. So I would like to invite all of you on here, and also you, Doctor. It would be really, really an honor if you would be able to attend the Health Awareness Day in light of the Breast Cancer Awareness Month, and maybe just give a brief overview or raise further awareness in terms of what you're doing around raising breast cancer awareness in the Gambia. I would really, really like, really appreciate that. And I'm actually the founder of Altogether Giving Africa. So I just wanted to put that out there. I've left the details in the chat and our email as well. So if anybody has got some time on that day, the 12th of November, from 8:30 to 4 p.m. You can contact Cherno Jaiteh or you can email us for further information. Once again, thank you so much, and thank you for allowing me to speak. Bye for now.
Okay, just one more question. Binti, I think you wanted to ask something.
I think in the basics, you would have some sort of sampling, because if you look at the guideline, there's still the issue of sampling. You may suspect that it's a malignancy, but if before you go ahead and do a mastectomy or a breast conserving surgery, you need to have pathology. So in the basic setting, you take the sample, but then send it to an area where you can actually have pathology studies. It would not be advised, and I think even ethically, you cannot do something like a mastectomy without proof. And when I talked about the triple assessment, that's a clinical, imaging, and histopathology. I mentioned histopathology is the most important. You cannot start any treatment, whether it's chemotherapy with all the side effects, or surgery, or radiotherapy without having confirmation. So even in the most basic of settings, histopathology is an essential tool. Yeah. You have to have it.
Okay, thank you so much. Yes. But be mindful that today is a half day. Okay, so it's almost midday. Please. Okay, just one more. Yes.
Yeah, so I mean, there's a slight modification to your question. It's not that ultrasound is not part of screening. Mammogram is the ideal imaging for screening, but I mentioned that ultrasound is an adjunct to mammogram, or when there is no mammogram. Adjunct meaning, in cases like you said, somebody who's 40 and above, and you have a strong suspicion that the person has breast cancer. You do a mammogram, breast cancer would appear white. You do a mammogram, the breast tissue is dense, it's white. So the chances of missing that is quite high. So either you do an ultrasound, which is cheaper and much more available, or in instances where you have a BRCA mutation, there are people who actually even do an MRI where it's available in order to be able to detect breast cancer. So what I meant from that is mammogram is your ideal screening test. If you go to most countries, when they're screening women, clinical breast examination, mammogram. But if you don't have it, then obviously you fall back on what you have, and that's all.
So, breast cancer, that is screening for 30 days.
Yes, it's ultrasound, and I think in the guidelines that's what was mentioned.
Because otherwise, you start thinking against ultrasound. That's what I said.
Yes, so if you look at this guideline that I said baseline assessment. So a baseline assessment here could easily be, for example, here, breast awareness, clinical examination, diagnostic ultrasound in limited settings, with or without a diagnostic or screening mammogram. So ultrasound is actually used in limited settings when you don't have a mammogram.
I have a portion of breast cancer. Back in 16, especially for the that said, when I get breast cancer, I have depression. So one side, what medication or this edge, that's best for the baby said, that's access to computer. That are women don't have the privilege of their business. So that's something that has to be have that and also breast cancer also wants to provide that's the molecular step. So that you can every patient profile and then you have treatments based on the profile, and then we can't hormonal receptors, we can't have radiotherapy, we can't do any monitoring. So I don't know where we stand to our breast management, and our breast management has been running many years now, and then I'm sure we got a lot of data. And still, I'm not seeing any push. We don't here, for example, the side and spoke to the place to be Dr. Lee, most is how far they come. But looking at it, and then many years, study, no one plan nothing. So now we are just able. I don't know where we are doing. I think it's fine. It's really interesting. They don't know about population. So that's it. And it's about the breast cancer, so they can say you are having an increase. Sadly, most women are becoming aware that looking for us. But there are many women who self-test examination, test monograph, who understand take their breast, tumor, they don't know us. Stop talking about it. I think this is what into and it's about best.
That's a very passionate plead, and I think since your days as general surgeon, things have moved a little bit in the right direction. I think you're absolutely right, and I don't believe it's just breast cancer, but I think cancer in general has to have a holistic approach. When I talked about management, I said it's a multidisciplinary management, and I think in order to give our patients the best care, we need to adopt that approach. Small steps are being made. For example, chemotherapy, as you know, in the department, we are trying to set up what looks like a chemotherapy unit, wherein you actually have chemotherapy being given by personnel who are trained to give it. Currently, we all know how our chemotherapy has been given, unfortunately, and steps are being taken in order to be able to have a unit like that. Maybe I might be jumping the gun a little bit on this, but the Ministry of Health is also coming up with a cancer unit. Dr. Bojang, I'm sure he'll make that announcement at the right time, but just to say that efforts should be made and are seen being made in that sense. If you're talking about radiotherapy, we need to at least know what our population is, like you said, the studies that need to be done, and eventually have a dedicated unit to cancer, breast cancer, and all other cancers, in order to be able to see how best some of these cancer fighting equipment and agents can be brought to the shores of this country. But I completely agree with you. Our patients deserve better, and we can definitely do better. Okay, I think Yago has a question.
also in the because they are they are ready. Now, when it comes to therapy, it destroys the cells, the normal cells, as well as but destroys the malignant cells more, and that's why we need science. Destroys more of the because of their rate of growth. So it destroys them more. So before the normal cells have before, so another side. We need to become serious about this. I correct you start with what is we have difficulty and we have conceived and made and over and over and every the patient was a complete response. And you have the chemotherapy, you have what we call non-responders, maximum responders. And we are going chemotherapy as the not complete, not withstanding according to still around
Okay, Dr. Sanya. Dr. Sanya. Dr. Sanya.
we are having patients with colorectal cancer. And the reason why I'm saying it is because cases whether they are less colorectal cancer, they come to the for metastatic. So the outcome will choose from getting I will finally want to ask that stand without whether side or side
All right, thank you. Can we do it another time in the next lecture series? Yes. Okay, thank you all for attending. You will still have the opportunity to ask your question and give contribution because this is a lecture series that is going to continue probably in the next 3 weeks. So please, time is against us. It's not on our side right now. So I will appeal to you so that we close the meeting now. The next lecture is going to be delivered by Professor Ogun, and this will include the histopathologic. It's a histopathologic look on breast cancer in general. So hopefully, Prof. Ogun will address some of the needs in terms of molecular diagnosis, genomics, and then the immunohistochemistry. Yes. Okay. So thank you so much for attending. Right? Thank you. Yes. Thank you. Okay. Yes.